All right, so yesterday we looked at some of the earlier things that were part of the pediatric infectious diseases, and they mainly involved the upper airways. So we had our bronchiolitis, croup, and then epiglottitis, and there were some critical differences between all of them that we delved into pretty well. Saw a couple practice questions, and majority of this is going to be based off of one to two key things you'll have to catch in questions to really figure out exactly what the problem is, because oftentimes they won't really try to spell the problem out for you that well. It'll more so just be that they're going to mention, X, Y, and Z, but not the key symptoms of each of the diseases. And then X, Y, and Z would be silly things that are related to the individual issue, right? So, like, for example, if they mention the tripod position, they don't really need to mention much else for you to know that it was epiglottitis, so they won't really help too much. And then they'll flood the question with a bunch of other random shit, like, oh, he has his vaccinations, or 2 weeks ago he may have had a tiny fall. Irrelevant things. A lot of irrelevant things may be in the question as well. And flooding is easy. Flooding a question is very easy. They can just be like, "Oh, mom and dad had a history of X, Y, and Z also," and it might be different X, Y, and Z. So, for example, mom may have had a history of breast cancer. Dad may have had like a history of MI 2 weeks ago or something. Silly random shit that isn't related to the child presenting today with epiglottitis. But just because they mention the tripod position, you would have to get it right. Right? Or if they mention a young child with excessive stridor, then you have to think of croup, and so on and so on. So make sure you get all that right. And then there's another table here regarding retropharyngeal versus peritonsillar abscesses. Right? So retropharyngeal being behind the pharynx, whereas peritonsillar is right behind the palatine tonsils. So theoretically speaking, the patient may present somewhat similarly, but there are some key differences that will help you really catch what the diagnosis is in the patient presenting in your question. So first thing, retropharyngeal abscess. This is usually someone from 6 months to 6 years of age, basically someone who has just started like kindergarten or first grade, right? So it's a young kid. Acute onset, high fever with sore throat, a muffled, what they refer to as a hot potato voice, trismus, drooling, and cervical lymphadenopathy, usually unilateral. A mass may be seen in the posterior pharynx on visual inspection. Group A strep is the most common cause. It could also be bacteroids or other things that are also technically normal flora of the mouth. Preferred position. So here we have its own thing, supine with the neck extended, right? So sitting up or flexing the neck worsens the symptoms, right? So flexing the neck worsens the symptoms. So they like to lay down and extend their necks, not sit up and extend their necks. Remember, sitting and extending your neck is the tripod position, but laying and extending your neck like this on the bed, or laying with your neck kind of hanging off the edge of the bed will make them feel better, right? Because it kind of opens up the back of their pharynx. And keep in mind that this is an abscess, which pretty much 100% of the time will have fever. So that's something to keep in mind, right? It's right behind the throat, and the infection is causing really bad fever in them. On lateral x-ray of the neck, the soft tissue plane should be less than 50% of the width of the corresponding vertebral body. This is difference that we were looking at yesterday when we looked at epiglottitis. Let me see, and we saw the thumbprint sign, right, on lateral frame. Well, where in the epiglottitis issue, which is a big emergency, the entire space for breathing is closed by the epiglottis sticking out like a thumb and practically choking, not choking because not the esophagus, but practically closing out the tracheal airway path. But here it's not going to be like that. The pathway for breathing is open. They don't really have excessive difficulty breathing per se. Contrast CT of the neck helps differentiate the abscess from cellulitis. So how do you treat this? You aspirate it, because that's generally what you have to do with any abscess. You have to drain it out. So aspiration or incision and drainage of abscess, plus of course antibiotics. Treatment for both of these is pretty much the same, but there's an additional thing here. You get rid of the tonsil too. Right, getting rid of the tonsil is a big part of it. Wait 1 second. Hey, what's up? Yeah, what happened? No, is there a problem? Oh, okay, all right. So wait, so if you're not meeting that person, then just swing by. Yeah, so just swing by over here. All right. Well, I guess I'm not sure what to say right now. Are you gonna do something like you don't even have any meetings or anything right now, right? Did you get to talk to Nikesh? Like what happened? Oh, yeah, that's pretty bad. All right, sounds good. Bye. All right. So compared to this now, we're going to see a couple different things here in the peritonsillar abscess. Theoretically speaking, though, in questions, they're both going to present very similarly. There won't be any major differences between the two. But here are the major differences. So the treatment, as we just saw right here, of course, it's an abscess, so treatment is drainage, but you have to get rid of the tonsil. Got to pull out the tonsils here, right? So tonsillectomy is the key thing. And then peritonsillar abscess, this occurs in more grown-up children. So now you're looking at someone who's kind of in the fifth grade, right? So age 10 and above. Tonsil, to get a tonsillar abscess, your tonsils also have to develop a little bit, and young kids don't really have enough of a tonsil to actually develop an abscess in there, right? They're gonna have a sore throat, muffled habitator voice, just like the retropharyngeal abscess, trismus drooling, and a uvula that's displaced to the opposite side. Right, so the uvula displacement. This is what we look for when we tell the patient to open their mouth and say ah, and you look at the uvula kind of moving in either direction. Right, this is related to the vagus nerve as well. Uh, same group of things that are basically causing the infection. So group A strep, and that's going to be the general thing. RS, aureus. No positioning that they prefer because this is peritonsillar, not in the throat, right? So when it's in the throat, that's retropharyngeal behind the pharynx. Let me see, like, so if we look at this picture to get the anatomy down, this kind of does the job here. Make it smaller. Okay, so like the pharynx stuff is right here, right? So this is all this pharyngeal area, right, behind. So anything that's coming in the mouth goes through here. So oropharynx, laryngopharynx, all that stuff, pharyngeal constrictors, it's all in the throat, all the way on the way to basically swallowing food. But then the tonsillar stuff is right there, that one. Right, you can see on both sides here. So if it's a single tonsil that's got the abscess, then the uvula would deviate to the one that's okay. And the uvula is kind of trying to run away from this abscessed, infected part. And then but however, even though it's not in the throat, it's still gonna cause them difficulty swallowing and stuff, which is why they're still drooling. Right? They're still drooling, so it's gonna be a problem in the sense that the general presentation is very similar. However, on physical exam, it's easier to look at the tonsils than it is to look at an oropharyngeal abscess because the tonsils are more proximal. They're right there. You open your mouth, you say if they mention the uvula deviated, that also really helps because that at that point is not a pharyngeal abscess. All right, it's like this is one question. You're gonna get one question if anything on this topic, and it's gonna have both of these answer choices. So you want to remember some of the key points for just getting it down and not messing up and picking the wrong answer choice. That's all it really is. So you make sure you study this just enough to get the key things down. Retro, much younger, peritonsillar, older. The tonsillar is on the tonsil. It could be both sides or one. If it's on one, the uvula deviates, and you have to take the tonsils out too. You take out both of them. Um, and that's generally it for that topic. Very simple little topic. And then comes a not so simple topic, meningitis. So bacterial meningitis most often occurs in kids under 3 years of age. Common organisms include as pneumoniae and meningitis and E. coli. Enteroviruses are the most common agents of viral meningitis and occur in kids of all ages. Risk factors include sinofacial infections, trauma, immunodeficiency, and sepsis. Give me 1 second. So we've seen tons of questions on meningitis. We've seen a lot of patients with meningitis all throughout step one questions. Now it's pretty much going to be the same exact presentation again, but they're going to mess around with you in terms of what to do next with the patient. In step one, it was always just what antibiotic would you give them, and it was a lot of like giving rifampin to all the close contacts, taking care of exactly what bug was causing the meningitis in the patient you're looking at. Now, in step one, first aid, there's this section, the system section under microbiology, that really breaks down things pretty well. It's a very helpful little segment. Let's see, I think I skipped it. Yeah, right there. Common causes of meningitis, right? So they break it down in terms of age group, and some of the more common things in CK questions about meningitis have been about the elderly patients coming in and giving them medications, because there's a special thing you have to do for the listeria. Listeria, which occurs on a bipartisan, a two-way kind of thing. Uh, So you can see it occurs basically in infants, and then it occurs in extremely elderly people. And we've seen that in the sketchy micro image where there's an infant and then there's a guy like Santa Claus, and it's all wintry because listeria is mainly found in cold cheeses and colder environments. Treatment of listeria is the only thing that's a little far-fetched from the other guys. Give ceftriaxone and vancomycin empirically to pretty much anyone who's got meningitis, right? And then you have to remember to add ampicillin if listeria is suspected. And this has been a question that comes up in CK quite a bit. So they'll give you somebody who's like 64 presenting with symptoms that are clearly symptoms of meningitis, and they're about to give them empiric antibiotics, and a bunch of tests are being ordered. It's going to tell you the questions they ordered, X, Y, and Z. Now they'll say what antibiotics should they give, and they'll pick ceftriaxone, vancomycin, and then they'll say what else should be given, and the answer choices are going to have a bunch of stuff. You have to add ampicillin for listeria. Also, I haven't seen any other treatment for listeria, so I really doubt they're ever going to have a question where they're like, whether the patient is ampicillin allergic or something. I really don't know what would be the case scenario there. Let me see if something pops up, because I mean, ampicillin allergies are a common thing. But I've never seen what to give in place of ampicillin allergy. Yeah, ampicillin alone or in combination with gentamicin remains the treatment of choice, and there's really not anything else they're mentioning that can treat listeria. Yeah, no further studies for antibiotics are still being held, but no results, so no changes there, right? So ampicillin, they'll hopefully not mention that kind of dumb thing, that the person is ampicillin allergic. Viral causes of meningitis, enteroviruses, HSV2, HIV, West Nile virus, and VZV. Right? These we've all seen in step one. Not so common in CK. HSV2 or HSV1 they both can cause meningitis and encephalitis, but generally speaking, HSV2 is with two people for sex. It's usually just going to be things related to STIs and stuff. HSV1 is going to be the number one cause of sporadic encephalitis. It could also be something that leads to meningitis as well. Not so sure you'll see much of West Nile virus on CK, but yes, of course you can see HIV and VZV, right, varicella zoster. In HIV patients, it's not the HIV itself that causes meningitis, but most likely the cryptococcus meningitis right there. So you have to make sure you go back to Sketchy or go back to microbiology in general and know the general treatments for everything the best you can remember it, you know. And if you don't remember it, then if you've done Sketchy, then that should help. If you haven't done Sketchy, then you know whatever you think is gonna help you get it down, you go ahead and use that to memorize that, because those questions are still going to pop up. So for example, this here, this is the cryptococcus sketchy microimage, which is in the Egyptian crypt basically. And in the back you can see the amphibian frogs to remind you of amphotericin, and this cone for fluconazole, right? So those are some of the easy ways of memorizing. And generally speaking, it was never so bad to begin with. And also that it's not exactly fluconazole you pick. The guy that's playing the flute is supposed to help you remember with the conazole that is flucytosine. But you could, and then you do have to add fluconazole eventually. I think I wrote it all here too. Number one cause of fungal meningitis, especially in HIV patients. And then, yeah, treatment is laborious. It's a lot of work, which is what he's doing too. He's doing a lot of work. Patients need joint therapy of amphotericin B, flucytosine, and then fluconazole. So we see all of that in the picture, right? And you want to make sure you get it all down for pretty much anything that you ever see a question on whenever you're studying, because these things just pop up. So here they list it out for you in a very minimalistic manner once again, but this is exactly what we were looking at in the systems segment for things that cause meningitis. This chapter in step 1 is great because it's a great place to come back and revise everything, see what the associations are, make your own notes for anything that you need to memorize, right? It's the same thing here. Like I would add notes here as well for how to treat each of these, anything else that tends to be a critical thing, you know, whatever else comes to mind. And you can see that the way they break everything down here is exactly what you get tested on, because this is also a huge deal in both step 1 and CK, right? What are your CSF findings going to be and why? So we're going to see, I mean, we've seen some of that already when we did neuro. We saw the things that were significant in CSF findings in different populations based off of the infection at hand or whatever. But it is definitely still a pretty popular and important topic. So all mentioned here pretty well. Bacterial meningitis classically presents with the triad of headache, high fever, and nuchal rigidity. Nuchal rigidity usually being the kind of sort of key thing that should ring a bell for meningitis. Viral meningitis is typically preceded by a prodromal illness that includes fever, sore throat, and fatigue. Now, they're never going to mention the names of these signs, but they'll talk about the signs as things being done part of the physical exam. So cardiac sign, reluctance of knee extension when the hip is flexed. Right? So they're going to mention some kind of physical activity that is not happening. So this is basically if you're standing and you try to reach your toes, right? Just try and stretch and reach your toes with your fingers, you're going to feel that your entire spine, the whole, there's a long, basically a tape that goes from the bottom all the way up, gets stretched, and that might actually limit you from reaching your toes. That's kind of sort of what's happening here, right? So they can't exactly stretch their meningeal lining that goes all the way down from the brain down through the spine with the different connections that are there, because it's all inflamed and tightened, right? So that's why they can't stretch. They also can't even just go like this, because stretching down, so for those not watching, people that can't see me, what I did is I was basically trying to get my chin to touch my mediastinum. They can't put their chin onto their chest, because to do that they have to stretch down the back of their neck, and the meningeal pulling that occurs there is not going to allow that to happen. So that's your Kernick sign basically. And then the Brudzinski sign, hips are flexed in response to forced flexion of the neck, which is what I was just doing, right? Flexion of the neck. That's your Brudzinski sign. So can't reluctance of knee extension when the hip is flexed, and if the hips are flexed, right? Sorry, if you're trying to do your neck flexion, then the hips get flexed. Basically, at any point, you can't stretch both things, right? You can't stretch the whole thing out. So if you have your hip flexed, your knee can't extend, And if you're trying to flex your neck, your hip gets flexed in. And in general, what you're basically going to see in the patient in its own normal position is that they'll prefer having their hip flexed and just sit there, because anything that lessens the pulling of their meninges. So if we look at both of these signs in a picture to get an even better understanding, let's take a look at it. So here we're looking at, let me find a good picture. Okay, there you go. This is perfect. This is actually perfect. These signs are much more apparent in younger kids like the one in the picture, because they have a smaller body and everything's much more responsive in a way. So what you're seeing here on the left side, Kernick sign, right? So the resistance to extension of the leg while the hip is flexed, right? So the hip is flexed. Remember, flexing means to, let me grab my pencil. So flexing is this action that's happening, that the hip is coming in this direction. Just like you move your arm in this direction to flex your bicep, right? So this would get big. So that's what's happening here, right? So they flex the hip, but now the knee is bent in, right? They can't get their legs straight. And so if this child was told to make his hand reach his toes in like somewhat of an ab exercise kind of pose, it wouldn't work. So that's your Kernick sign right there. Kernick starts with a K, and the issue here is that the K for the knee is gonna not want to let your leg get straight. So knee is extended, right? So knee is not extending, right? Because you cannot get your leg straight. You just can't. If he tries to get his leg straight, the pulling that occurs here is gonna pull down on his spine, and it's gonna hurt here, right? All of these things pull into the same direction when you try to make your leg completely straight, right? So that would be extension of the knee, which they can't do. Flexion of the knee, remember that flexion of the knee is when you move it in this direction, which is what he's doing, right? He's flexing in this direction. Right? Flexing of the knee, remember flexing of the elbow is different. Your arms and legs are kind of pointing backwards, right? Your elbow points this way, but your knee points that way because it's rotated during development, and that's kind of what we needed to be able to walk correctly. That's your Kernick sign. The easier thing to do is the Brzezinski sign. Super easy to do. You just tell the child to lay down, and then you try to make their neck touch their make their chin touch their chest, and you can see how naturally they're trying to squeeze their legs in. Right, so once again, the same thing is happening. The knee is not able to extend. The knee is actually flexing. The knee is always flexing. Right, so the knee is always going to end up flexing, and that's the flexing at the knee is going to be one of the key things that they might just end up mentioning in a question. This same arrow that I've drawn here, flexing of the knee, every single time. They have to flex their knees so they can stop the pulling of this meningeal aspect all the way down here. They just can't stretch it. They can't stretch it, right? Because it's inflamed. So that's generally all there is to that. And they love mentioning these things in questions, but they never actually name what they see. They won't be like, oh, there's a positive Kernick sign, or there's a positive Brzezinski sign. Most people have the name of these signs memorized for meningitis, but you don't need to memorize the name only. You need to know what exactly is the problem. So the problem is you can't extend all of your back. You can't make it nice and stretched out because of the inflammation of the meninges. So your knee is always going to be flexed. Right? The knee is not able to extend. Reluctance of knee extension. Right? The knee is always going to be folding in. Additional physical exam findings may include signs of increased intracranial pressure, papilledema, cranial palsies, or a petechial rash. Now, because of this, picking the answer choice of do a lumbar puncture is always there, and that's the wrong answer choice. You should never, in any patient, no matter what the problem is, you never really do a lumbar puncture without first doing a CT scan or some kind of scan, some kind of imaging that looks at the brain, right? Because if there is really bad pressure and you do a lumbar puncture, you could just pull the brain down. As the pressure gets relieved from the hole that you made in the lumbar area, all of that pressure is going to pull the brain down into their foramen magnum and instant coma, possibly death. Right, so that's going to be really bad. So don't pick that answer choice. Be very careful. So that's what they tell you here. Obtain a head CT first to rule out intracranial pressure. You need to rule out that there's a lot of intracranial pressure because there's a risk for brainstem herniation, as I just explained and described it. Um, if the patient is at high risk, perform a lumbar puncture after the CT once you've ruled out that there's no pressure to pull the brain down, and send cell count with differential, glucose and protein levels, gram stain, and culture, and check out what's happening, right? Based off of what you find in the CSF, you would know what caused the infection. Now, in step both 1 and 2, they've always used this table. They always love throwing this in there. And they'll always add an extra thing to it, too. They'll have other things like maybe RBC, right? White blood cell. They can throw in all kinds of things into it. So many different things to ask you about. But these are the main differentiating factors. For for CK, there's a better table actually. That table in step 1 isn't so good anymore. Where was okay? So it's probably neuro again. So let's go back and look at it. But before we do that, let's finish meningitis. So treatment: treat neonates with ampicillin, cefotaxime, and gentamicin. Remember the ampicillin for listeria. Consider acyclovir if there is concern for herpes encephalitis, like if the mom had HSV lesions at the time of infant's birth, or extremely bloody non-traumatic lumbar puncture, right? Because HSV does have blood in the puncture, in the lumbar CSF. Now, HSV lesions, we learned about in obstetrics that if a mom has active lesions in the vaginal area, then you do a C-section, like cesarean delivery. If the mom has no active lesions, then you could do vaginal delivery. Also, give older children ceftriaxone and vancomycin, because ceftriaxone for Neisseria, because older children are often in close quarters, and that's kind of where that spreads, right? Bacterial meningitis in kids over age 1 month, strep pneumo, Neisseria. Right, so some complications that can occur much later on do include intellectual behavioral disabilities, hearing loss, cerebral palsy, and even epilepsy. So you gotta be very careful with that. You need to treat this promptly, get rid of the issue really quickly. Don't waste any time. If we go back to, let me see, where do we talk about CSF findings? Really can't. But the step 2 version of those CSF findings things is so much better. It might have been here actually. Yeah, that would make more sense. Let me see. CNS infections. There we go. Yeah. So CNS infections, as we already looked at in infectious disease, meningitis, right? Same thing again. They're talking about all the stuff. Um, this here, by the way, is a bit of a misleading statement here. For meningitis, obtain a lumbar puncture for CSF analysis. That is the best initial test, yes, but you can't just do the lumbar puncture as we just saw, right? So obviously they're not doing a good job teaching this thing, because you need to do, and they mentioned it after. Like, some students don't even go to the next thing. They see that here, that's the answer, they learned it, and they're done. Like, you have so much to learn, you're rushing, right? But they tell you CT or MRI is indicated in a minority of patients before LP, in particular those with altered mental status, papilledema, or anything else that would have increased intracranial pressure. So what they're describing here is that generally speaking, you don't always need to do imaging if the chances of elevated lumbar puncture are not that high. That's actually a better way to tease this than what they mentioned in the pediatrics page. But generally speaking, you usually do it. There's no, because you're risking, the chances of what you're risking here is that, oh, you think maybe there's no high elevated intracranial pressure because it's just a kid. Why would he have intracranial pressure that's elevated? But what you're risking is, as soon as you do that lumbar puncture, the child dies. So you don't take that risk, right? The risk to benefit of just waiting and doing the CT is much better to do the CT, right? And they do tell you that if CT is being obtained, empiric antibiotics should be started beforehand. You don't need to waste time on starting the empiric antibiotics of the whole group of everything, right? Everything that needs to be covered, all 3 of them. So ampicillin, ceftriaxone, vancomycin, right? Ceftriaxone, vancomycin, ampicillin, just like that. And CSF findings. So now here you see a much more discrete breakdown where they can mention any of these things, right? But you don't need to worry about all of them. Let's take a look at first, making sure we understand what's normal CSF. So the gamma globulin thing is never going to be listed. Gamma globulin is only for multiple sclerosis. In multiple sclerosis, when you do CSF findings, everything's going to be normal except there's gamma globulin. So that's the only reason this is on the table, just for multiple sclerosis. So don't worry about gamma globulin too much. Now, normal is supposed to be clear CSF with an opening pressure of about 15, a protein of about 30, glucose. Generally speaking, your normal glucose is supposed to be like, I believe 60 and 70, something around that range. And then barely any red blood cells or white blood cells. Like, there's just no reason for there to be too many red blood cells, white blood cells. Very few. Very, very few. Now, if you jump into bacterial meningitis, one of the most notable features is that the bacteria will eat the sugar that's in the CSF. They need the sugar to survive. So, of course, glucose is going to be low, less than 40. Right? You need the numbers. I don't know why they're so shy about writing the numbers in, because your questions are going to present with numbers. So this table here kind of does that for you, right? Normal is 40 to 70 glucose. Bacterial meningitis has less than 40, right? So we see that right here. Bacterial meningitis is going to have low glucose and it's going to have high protein. So you can see that bacterial meningitis more than 250 protein. So I'm going to actually write that in here too. Well, I can't write it right now because I'm not saving the document, but I'll put that in there. Add it into here so you can look at it all together. So less than 40 glucose, more than 250 protein, and it's going to be a very cloudy appearing CSF, right? With a slightly elevated opening pressure, but not too much. The key thing here is just that sugar went down. Okay, sugar went down. Now you compare that to viral meningitis. Viruses don't eat sugar. They're not living things. So the glucose count will be normal, 60 to 70, 40 to 70, something around those range, right? But now what's really going to happen here is, since a virus in effect is an actual protein, just by existing, it increases protein count. So normal sugar and high protein, think viral meningitis. Low sugar and high protein, you think bacterial meningitis. So sugar being the thing, the living thing, the bacteria ate some of the sugar. The non-living thing, the virus, doesn't need any of the sugar, so sugar is normal, right? And since the virus is not a living thing, it doesn't really cause any dirt, so CSF is clear. Okay. Now, the only time it may not be clear is when you look at HSV related stuff. That's different. HSV is its own separate thing, so that's gonna fall more, HSV and so HSV is the only thing that's a little different from what's on the table here. That's, you're gonna have to do some practice questions on HSV itself, and you'll see what the correct answer there is. It's usually not a clear CSF. There's usually bleeding that occurs in that one. Aseptic meningitis and viral meningitis are theoretically the same thing, so I'm not sure why they have them as two separate things. If it's aseptic, it just means there's no bacteria, right? So aseptic meningitis or viral meningitis, generally speaking, the same thing. Subarachnoid hemorrhage. So now, of course, we've seen what happens with subarachnoid hemorrhage. Another scenario where you have to do the CT, you have to do a bunch of other things, and then ultimately, if everything is coming out somewhat negative, but you're pretty confident the patient is having a subarachnoid hemorrhage because of the extent of their headache and whatnot, and we looked at the workflow for how to manage subarachnoid hemorrhage when we were looking at the neuro chapter, then if you were really having a high suspicion of subarachnoid hemorrhage, you go ahead and do, now after the CT and all that stuff, a lumbar puncture where you're going to see xanthochromalacia, yellow, reddish CSF fluid, and that's when you know that this person has bleeding in their CSF and it is a subarachnoid hemorrhage. It's bleeding, right? And aseptic meningitis is supposed to also kind of encompass, again, it's just non-bacterial, so it also encompasses the cryptococcus, which is going to be the HIV patient having crypto. Generally speaking, it'll present the same. There is one thing though. Here they tell you, oh no, it's not this table. Damn. Well, if we look at, if we compare the two, we don't see any difference. No difference here at all. So the only thing that you'll really have is basically going to be what's in the question stem. If they tell you it's an HIV patient, then it's probably aseptic meningitis with cryptococcus, right? So they'll have to mention some other symptoms or something to help you see it. CSF really only helps easily differentiate between these two, bacterial versus viral. That's it. So this is all we're looking at for our case scenario right now with meningitis, all right? And then the cryptococcus doesn't really have anything else to it that makes it that different from the others, as you can see. So that's basically it for that topic. Let's see where we were. All right, so this now, next thing, ocular infections in neonates. So very important, very common to have conjunctivitis, right? Not so much in America, but it's very common in everywhere else. Like I've had pink eye in India so many times when I was little. Not so many times, but I remember two times definitely when I was in India that I had pink eye. Infectious conjunctivitis is transmitted as the neonate passes through the birth canal during labor, and the infection often presents during the first weeks of life. The most common causative agents include chlamydia and HSV. So for chlamydia, we usually do that erythromycin ointment thing. Neisseria gonorrhea was much more common before the routine use of silver nitrate for prophylaxis. Now, it only causes under 1% of cases of neonatal conjunctivitis in the United States. The table below is going to summarize some of the clinical presentations, and diagnosis is usually going to require bacterial culture in gram stain. That's the gold standard. HSV polymerase chain reaction is the diagnostic standard for kids with corneal ulceration. That's when you know that it's a viral thing. Or those with vesicular eruption anywhere else on the body, then you definitely think of, anytime it's vesicular, you think of HSV. The neonate's mom should undergo cervical gram stain and culture if a sexually transmitted infection is suspected cause of conjunctivitis. Treatment is with empiric treatment before culture results are known. You don't waste any time or the baby might go blind. For chlamydial conjunctivitis, give topical erythromycin, ointment, and oral erythromycin. Topical antibiotics alone are insufficient, as systemic infection is often present. For gonococcal conjunctivitis, give an IV, intravascular, or IM, third generation cephalosporin. Coverage of gonococcus is crucial if the causative agent is unknown, as corneal ulceration can occur within 24 to 48 hours. The gonorrhea one is really fast onset, whereas chlamydia is a little not so fast, it's slower, takes its time. So gonorrhea is basically acute, chlamydial stuff is subacute. For HSV conjunctivitis, treat with a 14 to 21 day course of systemic acyclovir along with a topical agent like vidarabin. So again, this is really only going to be complicated in CK based off of the answer choices of pharmacotherapy that you have to pick. Other stuff is not so bad. So here you have your three main causative agents you really need to worry about. Chlamydia, subacute, slow onset, symptoms appear 1 to 2 weeks after birth, presents with eyelid swelling and relatively scant watery discharge. Right, so chlamydia and sketchy micro was a bunch of clams out in the ocean, which will help you remember watery discharge. Neisseria gonorrhea, symptoms appear within the first week of birth. It's very fast onset, bilateral, purulent, right, very pussy conjunctivitis and marked eyelid edema, tends to be more severe than chlamydial conjunctivitis, which is why now every baby that's born has that silver nitrate thing. Right when they're born. Silver nitrate for prophylaxis gets rid of the Neisseria. And the HSV symptoms appear within the 2 weeks of birth. It's in between Neisseria and gonorrhea in terms of onset timing. But being that it's a viral thing, it's not really going to have so much of that pus as it is going to have the conjunctival injection and vesicular eruptions anywhere else, as well as around the body if it is itself herpes. If it's the herpes that's causing it, then yes, that's going to be, you're going to look for the vesicular eruptions anywhere possible. If you see vesicular eruptions, then you right away know the conjunctivitis is due to HSV. Right? This question here is related to, I think, meningitis. So let's take a look at it. 4-year-old girl is brought to the office due to behavioral concerns over the last 2 months. Her parents and preschool teacher have noticed that she frequently does not respond to their questions, and they often need to repeat themselves several times to get a response. So the girl is having trouble hearing. 3 months ago, she was hospitalized due to high fevers, headache, and nuchal rigidity. So that triad right there is 3 months ago she was having meningitis, which even caused recurrent seizures. So meningitis was so bad she started getting seizures. CSF grew as pneumonia, and she was given parenteral antibiotics for the MOPS pneumonic. Remember, for pneumonia, so the M in MOPS for meningitis. It also causes the O, which is otitis. The seizures were initially difficult to control, but resolved after 72 hours of antibiotic therapy. A repeat CSF was sterile, and she completed the course of antibiotics, so she completely recovered. She has had no fever or headache since then and has not followed up until today's visit. Vital signs and growth parameters are normal for age. In the office, she's alert, can hop on 1 foot, which actually proves that she doesn't have any inflammation. Because for hopping on 1 foot, you had to flex the knee on one and keep the other one really straight. Right, so this is showing that her feet are able to just stretch the meninges just fine, And plus, she has the balance. Her brain is working, so she's able to do that balanced action of hopping on one foot. She can also copy a cross and square on paper, which now there's you can see they're trying to fill the question with bullshit. What is the most likely cause of her current symptom? Where her current symptom is not exactly behavioral concern, but more so that she just cannot hear. Right. So when someone doesn't respond, you refer to that as being rude, but she doesn't have a behavioral concern. She's not a rude girl. She doesn't hear anything, so she's not responding. So why can't she hear anything? Well, obviously the question is only talking about meningitis, so it must have been meningitis induced hearing loss. Right? She already has the meningitis induced epilepsy. Now she's having meningitis induced hearing loss. Inflammatory damage to the cochlea. 60% of people picked it, while 30% of people chose recurrent 3 Hz spike and wave epileptiform discharges, which I would imagine is related to having an absence seizure, but she's not having that. The above table was given, this one right here. Um, she had bacterial meningitis and now ignores voices, raising concern for hearing loss secondary to her infection. Up to 50% of kids with bacterial meningitis have long-term neurologic sequelae, including intellectual and behavioral disabilities, hearing loss, seizures, and cerebral palsy. Risk factors include younger age, prolonged seizures, and high bacterial load at diagnosis. Sensory neural hearing loss, most commonly seen after S pneumonia and meningitis, is due to inflammation of the cochlea and or labyrinth and may not be immediately apparent. All patients with bacterial meningitis should undergo audiologic testing as soon as possible before discharge. So the real lesson in this question is the audiologic testing as soon as possible before discharge. She didn't have a chance for that, right? Because she had a different complication that had already taken place, which was the epilepsy, the seizures she was getting. So they wasted a lot, well, not wasted, they dedicated a lot of time into helping her with the epilepsy aspect, and then she never came back for follow up. So they never had a chance to do an audiologic test for her after that. So that takes care of that. Next topic, pertussis, the whooping cough. That was pretty big in step one. Really significant topic that they really enjoyed. Bordetella pertussis with the sketchy microimage right here. Gram-negative aerobic coccobacillus. Virulence factors include the pertussis toxin, which actually disables GI. So this is supposed to be a disabled GI, like GI Joe. So he's an army guy, and he's disabled because of his injury, right? So disabled GI. Adenylate cyclase toxin, high cyclic AMP, and tracheocytotoxin. So back here, what we're seeing is supposed to be the trachea, with the blue thing being a cytotoxin in the trachea. Right? 3 clinical stages: the catarrhal phase, the paroxysmal phase, and then the convalescent phase. The most problematic one being the paroxysmal phase. So it starts off with low-grade fevers and some coryza, right? So his eyes are looking a little reddish here. And then it gets to paroxysmal phase where there's intense cough followed by an inspiratory whoop. So that's what they call it, a whooping cough. You can listen to this on YouTube as well, Bordetella whooping cough, and you'll find videos where you'll see how it sounds. And then the convalescent phase is the gradual recovery, but that's like much later on. So by that phase, like, you're recovered and things are okay now. prevented by Tdap or DTaP vaccines, may be mistaken as viral infection due to lymphocytic infiltrate resulting from immune response, but it is not a viral response. So, sorry, it's not a viral infection. So this popcorn that he has are supposed to be lymphocytes. There's excessive lymphocytosis, but the lymphocytosis is not a sign that this is a viral infection. Right? The pertussis toxin's ADP ribosylation also disables chemokine receptors for lymphocytes, making them unable to enter lymphoid tissue. So lymphocytosis is simply because the lymphocytes are unable to go where they need to go, so they're kind of just stuck there. Right? That's all that's happening there. Now if we come back to here, highly infectious form of bronchitis caused by gram-negative Bacillus Bordetella pertussis. The DTaP vaccine given in 5 doses in early childhood is protective, but immunity wanes by adolescence. Adolescents and young adults serve as the primary reservoir for pertussis. Do not exclude it as a diagnosis in young adults with paroxysms of cough. Transmission is through aerosol droplets and requires airborne precautions with the mask, which everyone hates to wear, but it's very important. A mask is not a brand new thing, right? It's always been around. Surgeons and whatnot have always had to wear it, and clearly everyone that did wear a mask for the whole pandemic time also didn't get sick from many other things either. Didn't go through a typical cold, all kinds of many other things that do occur in general over a year span, like pre-COVID times. I haven't been sick in a mad long time. Yes, it's obviously masks do something. Pertussis can be life-threatening for young infants, but it's generally a milder infection in older kids and adults. So the most important thing is young infants and young kids in general, right? Anyone under 16, I would say, is a problematic point. But young infants is what they're going to show in questions for you. So you see a catarrhal phase with mild upper respiratory infection symptoms, a paroxysmal phase or paroxysm of cough with respiratory whip and post-tussive emesis. Now, really bad cough that then causes so much pressure, the coughing causes so much pressure that they actually end up pulling up any food that they ate and vomiting, right? So post-tussive emesis, after coughing, they can vomit. So if they give you a question where a child is presenting with so much coughing that they vomit, that is a giveaway for pertussis. No other infection causes so much coughing that you vomit, right? And it's not even going to be the first day of coughing that causes the vomit. They have coughing on a regular, right? On a regular, like they're coughing for. Here they tell you it's a 100-day cough. That's why it's a victory of 100 days war. It's a 100-day cough. That's very important. And the 5 doses right here, I broke it down for you guys. So diphtheria, tetanus, and acellular pertussis. Right, they're given together, DTaP. And then the Tdap is a booster vaccine given at age 11. Children should get 5 doses of DTaP, 1 dose at 2 months, 4 months, 6 months, around 15 months, and then again at age 4 years. And it may be given at the same time as other vaccines as well. Right, we also need to memorize vaccinations perfectly for CK. We needed to know vaccinations perfectly for step 1. So that's what this is all about. Okay, so very important to get that down. Patients most often present in the paroxysmal stage, but are most contagious in the catarrhal stage. So if someone comes in the paroxysmal stage and they have other people they were living with or other infants in the house, or they went to a party or something, people there may have been exposed to. Right, so we're going to look at the post-exposure prophylaxis soon enough. Diagnosis, labs show an elevated white blood cell count with lymphocytosis. As we just saw, the lymphocytosis is not to confuse you into thinking it's a viral issue. Right, so don't start thinking that it's a virus that caused whatever happened. It's just because, what was the exact thing actually? Yeah, the ADP ribosylation that occurs from the GI being disabled. Right, so ribosylation is always in sketchy micro showed by a bow. You see the bow he's wearing? Like that. Yeah, so if you watched these pictures being drawn and you actually used these to study back in the day, then it sticks to you pretty well and you know what's happening. And so ADP ribosylation also turns off the ability for lymphocytes to go to where they need to go. That's all that's happening there. Most accurate test is to do a nasopharyngeal culture or PCR. Hospitalized infants under 6 months of age, because the coughing and difficulty breathing is so bad that they can actually choke and die. Especially if they started vomiting, then they can have aspiration of the vomit and again choke and die. Give azithromycin for 10 days to patients. Exposed newborns are at high risk of are at high risk irrespective of their immunization status because they may not entirely be protected by maternal transplacental immunoglobulins. Keep in mind that although you're giving these vaccinations at the 2 month and 4 month and 6 month phases, you're giving the vaccination, but it doesn't mean that the body has taken it and developed immunity and become really strong. That's the key thing to keep in mind there. And so that's something that um, may get tested. Like, oh, the child is vaccinated, so you don't need to do anything. No, that's not true. You do need to do something, even if the child is vaccinated, right? So they're gonna try to trick you with that. They'll tell you that the child already got their vaccines, or they'll tell you a patient came in with Bordetella pertussis whooping cough, very evident, and then you treated the child. The child is okay now. The child also has another child in the house who was exposed, but the child has been vaccinated with the 2 and 4 month dose. Do you need to do anything? Yes, you need to give them azithromycin also, right? But since they're telling you that the child has been vaccinated, you might think you don't need to do anything, and that's not how that works. So you got to be careful with that. Okay. Close contacts, including the daycare contacts, should all receive prophylactic antibiotics, azithromycin, for 5 days. And so again, if the child came from a daycare, that's even more problematic because now it possibly could have spread to everyone in there. Right? Two questions here, so let's take a look what's happening here. First, they tell you at the top, key fact, classic presentation of pertussis is an infant less than 6 months of age with paroxysmal coughing, post-tussive emesis, and apnea. The typical whooping cough is usually absent at this age. So you look for the coughing and vomiting. 4-year-old girl is diagnosed with Bordetella pertussis infection after an outbreak at her daycare center. She has paroxysmal coughing fits and is prescribed a course of macrolide antibiotics, erythromycin. She lives with her 30-year-old parents and a 1-year-old sister. Her family members have up-to-date immunizations and are asymptomatic. What is the most appropriate way to limit the immediate risk of infection in her contacts? You see, this is exactly the question we're basically talking about. So it's good that I found it and I put it here. Prescribe a macrolide antibiotic for all household contacts, period. Just give it to everybody. There's no harm in giving it to everyone, so just give it to everyone. It's not a dangerous antibiotic. 15% of people chose administer pertussis immunization to all household contacts. That answer choice makes no sense. Everyone's already immunized, so that makes absolutely no sense. This is not a type of thing where you're going to do passive immunization and the patient's going to be okay. And then they have administer post-exposure prophylactic vaccination to the sister only, the 1-year-old sister. But again, they're already vaccinated. Right? All family members have up-to-date immunizations. So that means that this 1-year-old already got the 3 first doses that they're supposed to get. So that once again doesn't make sense. And then prophylaxis to close contacts is not required is obviously a wrong answer choice. Bordetella is really dangerous, and you need to be vaccinated, and even if you are vaccinated, you need to be treated if you were exposed. Everyone needs to be treated if you were exposed. Okay, so very critical thing there. Pertussis is a highly contagious disease transmitted through respiratory droplets. Patients have mild cough and rhinorrhea in the first 2 weeks before developing a characteristic whooping cough. Although patients are most contagious during the catarrhal stage, disease can spread up to 3 weeks after the onset of paroxysmal coughing spells. First-line treatment is with the macrolide, and this does not shorten the risk of transmission. So transmission, even with treatment, is possible. Vaccination prevents most pertussis cases. However, immunity can wane over time, and some immunized exposed to household contacts can develop disease. So this includes both the 30-year-old parents whose immunity may have faltered away, and the 1-year-old who is just too young to strongly be immune to it. Antibiotic indications depend on exposure history, regardless of vaccination status. So everyone gets the post-exposure prophylaxis, right? So age less than 1 month, azithromycin. Age more than 1 month, you could pick anything, azithro, clarithrol, or erythro. Now here's a question where the azithromycin was the answer choice, but only 40% of people picked it. Not sure why. 3-week-old girl, so this is an infant. 3-week-old girl brought to the emergency department due to apnea and cyanosis. Her mom reports multiple episodes over the last 48 hours of gagging and gasping for air. During the last event, she started coughing harshly during a feed and then stopped breathing. She became cyanotic for approximately 12 seconds, which is a breath-holding spell that commonly occurs, then quickly returned to normal. She has a 1-week history of clear rhinorrhea and increasing cough with episodes of emesis. That's the giveaway. It's a cough with emesis. that's been lasting for a long time and is becoming really problematic, Bordetella. Vitals are fine. She's well developed and active. There's nasal congestion, clear rhinorrhea. Lung sounds are clear except for referred upper airway congestion. Cardiac and abdominal exam are normal. What's the most appropriate empiric pharmacotherapy for her? For her condition. Azithromycin, 40%. How do only 40% people pick that? Right, this is an easy question. It's just Bordetella. It's very straightforward. There's nothing confusing in the question. 20% of people trust ranitidine, which is actually a thing for GERD, right? Ranitidine. But this patient doesn't just have heartburn. They're literally telling you she's having difficulty breathing and became cyanotic. So, that doesn't make sense. She has a severe cough with apnea and post-tussive emesis that is concerning for pertussis. But people focused on the wrong thing here and took the wrong road in the fork, right? They focused on the fact that the baby's eating and then vomiting. That's not all that's happening, though. The baby's eating, but the vomiting is because of coughing. And the coughing is not because of heartburn. So she has severe cough with apnea and post-tussive emesis that is concerning for pertussis, right? It literally is in the name, pertussis. Right? So post-tussive emesis, which they never use in the question, but you need to think of vomiting after you're coughing as post-tussive emesis. Highly contagious infection that is caused by Bordetella pertussis and transmitted through respiratory droplets. Infants plus unvaccinated individuals are at high risk. Vaccination is recommended on the routine schedule. Ranitidine is an H2 blocker for GERD, but GERD does not cause rhinorrhea or congestion. Right? So that's it for that. Now, in our next session tonight, we're going to go through viral xanthoms and torches infections, which are very significant. So I want to have that in a separate video of its own. These torches infections, especially measles, where you have the rubeola versus rubella, very critical, right? The differences and the presentation of the rashes. We're going to look at a lot of pictures to really get down confidently and perfectly what are the differences between these rashes. How do they all look different? Because they look very different. So you gotta know that confidently, right? They look very different. We have to know that confidently to be able to differentiate it, not just visually, but also how it's verbally described, whether it's a confluent rash or a general rash that's spreading places but slowly spreading, right? And you see the confluency of this rash, whereas slowly spreading, not so confluent rash, right? So we have to make sure we get that down, right? And we'll do that later tonight on our 6 p.m. session. So thanks a lot for joining. See you guys later tonight.